that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
Good afternoon. How are y'all doing? Good? Good. Oh, it's good to see some smiles out there. Good. I thought this morning whenever I left my house and it was raining, I thought, oh my goodness, the last time it rained and I used V-tail, which we're not, don't have that today with the distance sights aren't in, but I lost my V-tail. I thought, oh my goodness, you know, I lost that connection because it was lightning and thundering in Del Rio, Texas last summer when I was teaching a management course. I teach in the acute nursing department over in the nursing school, and you may have on your handout, if you've got a handout, that I'm Dr. Judy Criner. I am not Dr. Judy Criner. I am Judy Criner with a master's degree working on her PhD. But I'm not there yet, and whenever I got the material and it said I was doctor, I went, oh, yes, yes, I don't have to finish. But I do, so I'll continue on. And that's why I'm interested in this particular area. It's because of my interest in my PhD studies is in actually urinary incontinence with the use of Kegel exercise in military women specifically. I am an Army Reserve nurse as well as a professor over here at this nursing school. My husband's active duty. I teach in the acute department. I'm an ICU nurse. So I'm just kind of like a broad base here of information. Normally I work in an ICU setting, and that's where I take my students. I take my students to Brooke Army Medical Center, and we do clinical in the evenings at Brooke Army Medical Center in the ICUs and the ER. And in fact, right now I'm teaching an ER course at the Health Science Center for nursing for the undergraduate course as an elective. I enjoy working in the ICU, but I also know as an Army Reserve nurse that urinary incontinence is a problem that not only our older clients are faced with, but also young women as well. And it's something that has happened that they've really been studying a good bit on with the younger soldiers, female soldiers in the military, because of the activities that we have to do as females when we're out there in the field. I'm a field nurse. So I have to go out and I have to put up these big, huge tents they call det meds. I have to carry heavy equipment. Det meds. They're not just a regular tent. They're much heavier, and in fact it takes several people to put these up in a field environment. And because of the type of exercise that we have to do as military people, it's made young women prone to stress urinary incontinence. So that's where my area of expertise is right now. Of course, we know that as we age, we also are more prone to urinary incontinence. And in fact, women are more prone to urinary incontinence even than men. Urinary incontinence affects people of all ages, even though this is supposed to be geared toward the geriatric environment or people that are getting older. We all are, as we sit here, are getting older. So actually this could apply to anyone. It results in adverse psychological and adverse sociological consequences, and we're going to talk about that in a few minutes. I didn't feel like I could talk about behavioral therapies for urinary incontinence besides just touching on urinary incontinence first and giving you a little history in that before we go on and talk about, you know, what can we do about that without giving them drugs and without, you know, having surgery. So if you look at urinary incontinence and you look at half of our nursing home residents have urinary incontinence. There's been numerous studies out there with nursing home residents, and more than half have urinary incontinence. And 13 million suffer from some form of urinary incontinence in the United States. 13 million people in the United States suffer from some form of urinary incontinence alone. Two major risk factors for UI that we found in our nursing home population is the immobility and dementia, and that's really related to the dependence. That when people are independent or dependent on others, then they're more prone to have urinary incontinence. In fact, there's been studies out there that show that if with dependence, then urinary incontinence increases in our nursing home population. Urinary incontinence is involuntary loss of urine that is a social and hygienic problem. And this is very true. All you have to do is watch TV now, and it's all on the TV about the different medications that we can give our clients for urinary incontinence. You can pull it up on numerous websites. And all you have to do is talk to people about what's, if they have urinary incontinence, tell me about it. How does it affect you? And it can be very embarrassing whenever you're out in public and all of a sudden you lose control of your urine, whether it be dribbling or whether it be loss of a large amount of urine. I read a case study, I guess it was a couple of weeks ago, about a lady that was giving a talk, a professional giving a talk in front of a large audience. And she had urinary incontinence, and she urinated all over herself, and the embarrassment that she felt as it was running down her legs, and she had no control over that. So it's a major problem. Approximately 2.6 million older adults have moderate to severe urinary incontinence. So behavioral therapy is not for everybody. It doesn't work for everyone. It would work for those with mild urinary incontinence, and different types will work for those that do have moderate to severe, but different types of therapies. And it's one of the major causes of institutionalism of the older adult. One of the major causes of why we institutionalize adults. And they have found in studies that people in rural communities are institutionalized actually more so than those that live in the cities with urinary incontinence. It does increase with age, but it should not be considered a byproduct of getting older, okay? Because there are some reasons that our clients have urinary incontinence, and it's not because they're getting older. It's things that can be taken care of. Maybe it's the drug that they're on, or maybe it's because they have a certain type of urinary incontinence that just merely rearranging the environment would help with that client. So it's not necessarily just a symptom that goes along with age. And then many are not aware that incontinence can be treated. And that's one of the major problems that we have out there still, even now, after all the work that's been done with urinary incontinence, is the underreporting and undertreatment. A lot of people are embarrassed to talk about it. They won't mention that they have urinary incontinence. I think it's, I don't say it's funny, but now it's hyperactive bladder. You hear the hyperactive bladder or the overactive bladder. All I can see is this bladder that's just going crazy, kind of like my child when he was young. He was hyperactive, But it just sounds better. You might say, I've got an overactive bladder, but you're not going to walk up and say to somebody that I'm incontinent. Because most people won't do that. That's why there's underreporting and undertreatment, because most people are still too embarrassed to talk about the side effects of having incontinence and all the reasons why people will not go out in public, and your older adults a lot of times stay at home because of their limitations because of the urinary incontinence. And then certain conditions can cause or can contribute to incontinence. We also know that urinary incontinence can cause things like skin breakdown. There's a problem there. Infections. In our nursing home populations, urinary incontinence can cause sleeplessness, insomnia. And in fact, Dr. Oshlander has done a lot of work with nursing home patients where he looked at, with his cohorts, looked at what causes people not to sleep well and what kind of programs do we have out there for urinary incontinent patients in the nursing home. I was involved last summer. I did an extensive search with some people in Austin, and we were looking at urinary incontinent patients in nursing homes in Texas. This was with Department of Social Services, I believe. And we looked at what are we doing? What are we doing out there? Are we doing anything in our nursing homes in Texas for patients that are urinary incontinent? I can tell you, I was rather surprised. I did like a meta-analysis on a lot of different studies, and I looked at what we're doing. We're not doing much. There were very, very few institutions that actually were using any type of behavioral therapy, and if they were using any type, it was usually prompted voiding, and we'll talk about that in a few minutes. But most of them, what do you think they used? Pardon?
I was going to just say that depends.
That's it. Pads. pads. And they were also looking at sleeplessness, interrupted sleep in our elders, and a lot of it had to do with the type of continence practices that we use in our long-term care facilities. Okay, so most of the time, the problems that we have, it might not be necessarily the person who's incontinent, it may be our caregivers who are taking care of our patients, because we have a routine, don't we? Now, I know how nurses are, because I'm a nurse. Now, I don't have a clue what your professions are, but I know about nurses, you know, especially ICU nurses. We have a routine. By doggies, we're going to stick with that routine. I don't care. And a lot of times that's the way it is. We'll stick with the routine of every 2 hours just going in there, flipping them over, changing them, not doing anything else, interrupting sleep, when in fact if we try to institute some sort of a program, you might actually be increasing the quality of life for that patient in that hospital. Doesn't necessarily increase the quality of life for that nurse or that attendant who's taking care of that patient, because it's much easier, isn't it, just to go in there and every 2 hours just talk and flip patients over and change their pads and whatever, or don't even have pads on them, just put pads on a bed. You know, I've heard people tell patients, well, just use the bed. Just use the bed, you know. And I'm sure that some of you have heard that before too. It's easier for me to clean it up. Just use it. Okay. Some of the risk factors then, I've just mentioned some on your handout, some risk factors that lead to urinary incontinence, some that can be changed, some that can't be changed in our clients. Medications, if we think about when we give our diuretics, a lot of times we give our diuretics at night. It could just be something like manipulating medication that we're giving. Or it could be these are some of the things that can't be changed necessarily, but some medications can be changed. But environmental barriers, if we think about a patient that says, I know when I need to go, I know when I need to void, but the urinal is not where I can reach it. I did a study in Hawaii when my husband was stationed there, and I was at a large county hospital, and the study that I did was using prompted voiding and some habit training on different clients. And one of my clients that I had in the study, he actually had a stroke, but he had one arm that, his unaffected arm that he could use for a urinal, but he said the problem wasn't that he couldn't reach the urinal, or he couldn't manage it, or he couldn't be taught how to use the urinal with the hand that was not normally his dominant hand. But the problem is that it was never where he could reach it, or he couldn't get the call light, or they wouldn't come when he would call. Okay. So sometimes it's just a matter of changing the environment for our clients. I had one lady in my study who slept on the floor, believe it or not. She slept on a mattress on the floor. And this is because this is how she slept at home. She felt comfortable on the floor, and I thought that was a plus in some ways. I can't imagine some of our long-term institutions letting our patients sleep on the floor, but this particular woman, they allowed her to do that. And it was a matter of manipulating the environment so she could get to the toilet. Urinary tract infections, take care of the infection, might actually take care of the incontinence. Impaired physical mobility or ability, actually just manipulating the environment for these patients, or getting help for these patients, or helping these patients actually get to the urinal or to the toilet. Okay, that's simple, but sometimes it's a lot simpler than it's made difficult. Diuretics and caffeine, it might just be it's the factor that we need to cut down on the caffeine at night at a certain time to help those patients that are incontinent at night. We have found that patients actually, they usually have 6 to 8 incontinent episodes per 24-hour period, and usually more at night, larger amounts at night. Okay, so it may be that it may be the medication, it may be what the patient's getting on the evening tray that might play a part in that. Disease side effects, alcohol, drug side effects, and excessive fluid intake. One of the most common types, and I'm going to just briefly talk about these, one of the most common types is stress urinary incontinence, before we get into some of the therapies and some of the treatments. Stress urinary incontinence usually see mostly in women, more so than in men. Okay? Not saying that men can't have it, but mostly it's in women. And there's a lot of reasons for that. It's the most common type of urinary incontinence. This is the one that you can see in young women and in older women. A lot of times it's because we've had so many babies. As far as females, they have vaginal bursts. They may have some vaginal tears. It may be they've had an episiotomy. It could be the use of the forceps. Could be low estrogen. There's a lot of reasons. Obesity. But this is involuntary loss of urine that occurs when we cough, laugh, sneeze, do any type of activity. In fact, this is called activity-related incontinence. This is the one that you'll see in our young athletes, young women that are out there. Our athletes complain of stress urinary incontinence. And that's because of that heavy pounding that they do and that type of exercise that they do. Those type of activities like running, high impact. I think about, we have a lot of older women now that are still out there doing different types of aerobics. How about Taebo? Has anybody tried Taebo? That's pretty high intense. You do a lot of pounding, jumping, kicking. So women that are very active, of course, as we age, it just kind of adds to it, are more prone to stress urinary incontinence. Lifting heavy objects, that's why the women in the military especially are more prone to SUI, because of the type of activity that we do with our running, our PT that we have to do in the military. And also, if you're a field nurse, like I said, and the type of activities you do in the field with your lifting, pulling, tugging. If you're a field nurse, you are required to go out there and work with everyone else. It doesn't matter what your rank is. You're out there working. I see one lady over here shaking her head. She knows what I'm talking about. But you are. Whatever's going on, if it means carrying lumber from one end of a field to the next end of the field, it doesn't matter what it is. You're out there doing it. So they have found that our female soldiers are at high risk for stress urinary incontinence, and in fact do have stress urinary incontinence because of the things that are required of us. Also, it may be just a few dribbles. The person may complain of just dribbling just a small amount, or it may be a large amount. And it also may be a combination. It may just not be just stress urinary incontinence. It may be urge incontinence as well. Urge incontinence is the involuntary loss of urine that you have a strong desire to avoid. Men have this a lot, especially after if they've got an enlarged prostate, or maybe even after prostate surgery you might see this. Can't hold it long enough to get to the bathroom. They know when they've got to go, but they can't hold it. It comes. There may be a trigger, like running water. Could be the trigger. They hear running water, they have to avoid. Or warm water, sitting in a tub of water, this sort of thing. Common cause is involuntary bladder contractions with urge incontinence. Also, there may be some type of a neuro lesion, a stroke may be the cause, or aging or atrophy could be the cause of urge incontinence. Females can have urge incontinence as well. In fact, they may have the combination of stress and urge. Overflow, it means the inability to properly empty the bladder. Now, if you work in a healthcare setting, you know a lot of patients, or you've worked with patients that have overflow incontinence. They may not feel the sensation to urinate. Common causes are the decreased bladder contractions and the narrowed urethra. Not uncommon in some of our older clients to have overflow incontinence. Mixed is just a combination. They may call it mixed incontinence, but it's a combination of the urge and the stress incontinence. And you may see it in older women, but like I said, you can also see this, the urge and the stress, in our younger population, especially young athletes. They've done some work with women, young athletes, not necessarily just in the military, and found that this is very common. And how do you think that they take care of themselves if this is a problem? Pads, definitely pads. Young and old use absorbent pads. And the same thing for our athletes. They'll wear pads before they go out and run those, whatever they're doing, the activities that they do. They'll wear pads for that. They'll either wear pads or they'll come to some resolution. I'm either going to have a problem with this. I'll wear a pad and take care of myself that way. I'll go to the bathroom and void more frequently. That's another way that people take care of themselves. It's why that sometimes it's not reported and not treated. It's because of people take care of their own personal protection methods, I call it. They do their own personal protection things, like going to the bathroom every 2 hours whether they need to or not. try to avoid. Watching what they drink and how much they drink and when they drink. Wearing pads constantly in case they dribble or in case they have a problem with a lot of outflow. But for those runners, that high impact, constant impact, they usually will wear pads. Or they'll stop what they're doing entirely. That'll be one reason why they will quit what they're doing. It's because of that problem, and they won't seek help to see if there's anything that can be done for it. Functional incontinence is what I found in most of the time in the patients that I took care of in the nursing home in my study. They mostly had functional incontinence. They had problems with stress or urge, but they also had functional incontinence. In other words, it was outside of the bladder. It was something that could have been manipulated, and if it was manipulated, it could have been controlled somewhat. Not saying that with behavioral therapy that that's going to take care of everything. It doesn't necessarily, but it may decrease the episodes and improve quality of life. It may be enough that they're happy with that that's all they need. They don't need to be totally dry, but if it's just decreased somewhere, somewhat, so they can go about a normal lifestyle. And that's usually what is the problem, is that most people with severe incontinence can't go about a normal lifestyle. UI leads to low self-esteem. We know that. It's been documented. There's a lot of research out there on quality of life and low self-esteem. Leads to a decreased independent lifestyle. Leads to fear of an accident. People will not go out because they fear if they go out, they're going to have an accident. Leads to silent suffering because they won't talk about it, because it's not one of those things you talk about at the dinner table. Oh, how was your incontinent episode today? No, we don't talk about it. It's just not one of those things that we discuss. It's kind of funny because we'll discuss other things, but there's something about urinary incontinence we won't discuss. It's an embarrassment. For one thing, you think, oh, I'm getting old. I'm getting older then. Maybe that's it. So people don't talk about it. It's disabling socially and economically. And if you look on your slide, $16 billion a year is spent to care for urinary incontinence, up from $8 billion in 1988. Now, that's not as of '99. That's still a few years back. But you think about how much that we spend for urinary incontinence and how much the client spends. It would be amazing if we actually knew the cost of the client just on pads alone. For all the many people out there that use pads, some type of absorbent pad, we'd probably be overwhelmed. You think about people that are hospitalized because of urinary incontinence and how much that costs. Supplies, laundry, hospitalization, and then also there's underreporting and undertreatment, like I said. That's one of the major problems with urinary incontinence still today, even with all the advertising, even with all the research that's been done. Behavioral therapy, then, is one way that we can treat urinary incontinence. And the Agency for Healthcare Policy and Research actually recommends this to be the first line of treatment before we go to drugs and we go to surgery and other type of invasive procedures. They recommend this as one of the first lines of treatment. Try this first. If this works, that's great. The quality of life for the client will be improved. We won't be spending any money. We'll be spending time and effort, but it's much better off for the client because there's no side effects. You can decrease the frequency of UI or sometimes eliminate UI entirely after we've used these techniques for a while. We can, it doesn't necessarily mean that we can't use other treatment options as well. We can. If this doesn't work, we may want to use it with maybe some sort of drug, or maybe the patient will have to have some sort of surgery because this is not for everyone. But it requires education and positive reinforcement, and it requires compliance. And those are usually your main things right there, trying to get people to be compliant to a regimen like this, trying to get a caregiver to be compliant. It's easy for me to stand up here and say, this is what we should try first. Knowing that in long-term care facilities especially, if you think about the staffing in long-term care facilities and who we staff our long-term care facilities with, we need education. They need education. Whenever I did my protocol at Queen's Hospital, actually is where I did it in Hawaii, in Honolulu, I did it in a long-term care facility, a part of that hospital. And when I did it, I had to, you have to have buy-in. You've got to have buy-in from the people who are actively going to be participating. You've got to have buy-in from the client. You've got to have buy-in from the caretakers. because they're the ones that are going to be doing it. They're the ones that are going to be making sure that those clients have some sort of method and that they're sticking with it and that they're actively participating in this. They have found that that's actually the biggest problem that they have found with any type of behavioral type therapy that we use is not necessarily the client. The client said, I would still do this, but it's the caregiver. It's the caregiver who doesn't maintain it, doesn't keep up with it. Okay. When I did mine, I came up with a care plan, a type of care plan, and I would have meetings with, I would go at report, and I would sit down with the people that are going to be taking care of the clients on that long-term care facility or in that long-term care facility, and I talked to them about the program and what I wanted to do with the clients. And I did I did like a mini-mental type of a survey first to see which clients would be good ones for this particular protocol, and I looked at their ability to be able to handle activities of daily living. I think I did the CATS ADL type survey. So I did some things before that, and I got input from the caregivers as well. Who do you think would be the ones? Because they need to feel like they're a part of the program. It's nice for you to go in and implement a program, but if you don't get them to buy in, and if you don't get them to accept it and for it to become a part of that person, then you're wasting your time. So I got their input. Who do you think? Give me some clients that you think would be, appropriate for this protocol, and they did. So then what I did is I would meet with them in the mornings, and I would meet with the clients, or not the clients, but I'd meet with I can't even talk, I'm going to have a drink. I'd meet with the workers in the morning and in the evening, right when they were at change of report, and we'd talk about the protocol. And then I wrote the protocol up, and I said, this is what we're going to do. And I would go back and I would check and I would check and I would check to see if it was following through. But I can tell you that once I left and once I went back to check to see if the protocol was still going, what do you think? No, it wasn't. Yeah, it failed because it was time consuming, it was more time consuming for the healthcare workers. I mean, they had to actively be a part of going in and doing something every 2 hours, and not necessarily on their schedule, but on the client's schedule. So that's one of the faults of the behavioral training. You have to have buy-in. Toileting assistance includes scheduled toileting, habit training, and prompted voiding. Prompted voiding, like I said, is the one that's used most often. If you're going to have a training type program in long-term care facilities, they found that prompted voiding is the one that's used. And I found that as well last summer when I was working with this research study, and I did this lit review, extensive lit review. I was just amazed that there weren't any more programs out there. And that's one reason why in the future that's supposedly going to be instituted. It's not through yet. They're still working on this. And it's just coming in the near future that they're going to have some sort of a plan and some way to check to see if indeed they're following up. Toileting assistance should be offered on a consistent schedule. This is timed voiding. You may have heard it called time voiding. Whenever the patient you get the patient up every 2 to 3 hours or 2 to 4 hours, even at night, to void. Actually, this I've got on the slide not successful if cannot participate, but actually that's wrong. This is good for patients that cannot participate in independent voiding. Most of these people are dependent that you use this with. They maybe have a spinal cord injury. It doesn't matter. You're not trying to get them to hold back or not to hold back an urge. You're going to take them to the restroom every 2 hours for them to void. Now, they have found in studies that this works, but it makes sense that it would work somehow, doesn't it? I mean, if you're going to take patients every 2 hours to the restroom, even at night, it makes sense that this would decrease their incontinent episodes. Habit training, you need to establish a normal voiding schedule for the client. It's excellent for hospital or home use. You schedule, you make the schedule around the client's voiding habits. Usually you do like a bladder or some type of a bladder survey or a voiding chart or a bladder schedule or whatever. You get the client or the caregiver to actually document how often the client is incontinent. And then you make your schedule around that with the habit training. Compliance with habit training with staff members has been found to be one of the major problems with habit training. Prompted voiding, the client needs to recognize there is some degree of fullness with habit voiding, with prompted voiding. And 3 parts of that is monitoring to see if the client is wet or dry. And if the client tells you and able to tell you, yes, I think I need to go to the restroom now. You go check, the person's yet dry, person's wet. You do some reinforcement at that point. You prompt them to go to the restroom, and then you make sure you praise them when they're actually able to tell you, I need to go to the restroom. Okay. So this takes work from the caregiver and work from the client as well. And it seems to work. The research that I've done on prompted voiding, and that's what I used mostly with my clients in my study, seems to work. In fact, they found that it works over months at a time, as long as you can have compliance with the people that are actually working with the client, and as long as the client is able to tell you or to feel some sort of urge to go to the restroom. Bladder training, we've had bladder training for a long time. It's called bladder drill, it's called bladder retraining. It's been around for a long time. I can remember doing this when I first got into nursing, when we would actually try to get the bladder full, extend the period of time before the patient go to the restroom. The whole period, you look for you aim for a longer interval between voiding. It works for some. It doesn't necessarily work for others. But the goal is to correct the habit of frequent voiding. That's the whole goal of habit of bladder retraining. The one that I have seen used, and there's a lot of research out on right now, is pelvic muscle exercise. Pelvic muscle exercise is used quite often with women with stress urinary incontinence, with urge incontinence, and with men after prostatectomies. And this seems to work very well. You have to have education, of course, like with all the other types of bladder training. You have to teach the client how to isolate those pelvic muscles. So it takes education on the part of the caregiver, and it takes compliance. In fact, I was looking in my email, I don't know how many of you guys get Medscape. Any of you guys have the email address to Medscape? You can get some excellent information off of Medscape, and I was pulling up, I always ask for the Medscape on the urology and the oncology and the cardiac. It's an excellent website, gives you excellent articles right there on, this comes right to your email. And there was something in there about pelvic muscle exercise, even yesterday, talking about compliance 10 years later and how it works and how it's effective if it's kept up. It's one of these things that you have to keep it up. It's not going to work if you don't maintain pelvic muscle exercise. But it does work for mild to moderate urinary incontinence. It wouldn't necessarily work for severe incontinence, but for mild to moderate, it has found to be effective. So some of the strategies then that you can use, we talked about a few of the strategies, didn't go very in depth because actually they're not that difficult. It's a matter of just setting up your program, finding out, okay, what does my client, which one would work for my client? Which would work for a client that's cognitively impaired? Which would work for this client? Is this client independent? What kind of urinary incontinence does my client have? How severe is it? And it would take more than just saying, well, I'm going to try this on this client, because you've got some studies that you could do before that, do assessments on your clients as far as their activities, what can they do, how severe is the incontinence. You need to check all that out before you decide which program or which type of training would work for your client. Pelvic muscle exercise is a fairly easy one to do. It's just a matter of teaching them the right way to isolate the muscle. And then once they do it and they learn how to do it, you can do pelvic muscle exercise anywhere. You don't necessarily have to be lying down. You could be standing up. You can be sitting and do a pelvic muscle exercise. It's pretty intense, because once you teach them how to do it, they usually do it in like 6 to 10 times. They'll have a period of rest, and then usually it's up to 60 times a day. I mean, but so you see that you need to do it. You know, you could do it in any position actually. So the strategies are important, but the strategies are useless unless you actually use the strategies. And you go out there and you find out more about them. And if the client can use a strategy, and if the caregiver is willing to use a strategy, it's useless unless you have support. Support from the caregiver, whether it be in a long-term care facility, in a hospital, or in home, or commitment. You've got to have commitment. It's not something that's just going to work overnight. Sometimes these strategies take months. So you can see that if you're into a long-term care facility, you've got limited staffing, that this could be a problem unless you've got buy-in from the caregivers and they see the value of this. And then evaluation. Does it work? Is it not working? Okay, if it's not working, what can we do? Go back again and look at a different strategy. What do we need to do for our clients? The conclusion is that behavioral training requires training, of course. You just can't go out and do this unless you have some type of training, and you're going to have to train the people wherever they might be. Motivation, you've got to be motivated to do this. That's why it might not work for a client that's actually independent. You've got to be motivated. And persistent. The bottom line is quality of life for our clients, and if we can decrease, not necessarily just do away with entirely urinary incontinence, but if we can decrease the episodes, then people have said in different research studies that, hey, I had this many urinary incontinent episodes, but now I only have this many. I'm happy with that. And it may be that's all they need. They may not need to go on to any type of drug therapy. They may not need surgery. And if they're happy with that, it might work for them for a while before they need to go on to something else. Any questions? Okay, thank you very much.
Well, it's that time of the season, and all through the house